Thank you so much, colleagues, and apologies for not being with you. It certainly looks like an extremely stimulating group that is there. I'm acutely aware that you have people in the room who will be able to talk very much more specifically about the New Urban Agenda, and Remy, and I saw Jeannie walking around. And so part of what I want to do in the time that's available to me, I can't see the video of where you are, which is not a problem, but I'm assuming you have some slides up there. Is that correct?
Yes, we see your slides. So you
can see the slides?
Yeah, we can see it.
I think you'll just have to kind of work your way through them, and if necessary, I'll indicate. But I think if you just try and listen to the context that I want to be able to sketch, effectively what I'm trying to argue is that this is a really useful moment for us to be stopping and thinking about the urban health question. And the reason is that there are, in addition to all the reasons that we associate with the primacy of cities, the fact that we have a majority and increasingly a predominantly urban population, there is, in a way, a global consensus that is foregrounding and enabling a shift in the way that we think about global health ideas, practices, and partnerships. And part of that is, of course, because of the demographic shift. And I don't have to remind a meeting about health that the question of urban population growth is, in the first instance, a question about whether or not there is a met demand for family planning. I don't have to, perhaps I do have to remind a group that is dominated by health professionals and others that some of the spatial dynamics of development, which see the concentration of investment in cities, is leading to a shift in the burden of disease and is also opening up alternative entry points into disease mitigation.
Sue, apologies, Sue, but are you able to move your slides, or should we do it? In case we do it, then yes. Did you do this now?
I'm not on the same system as you, so I think you have the slides. It's better if they're there. I'll try and say move the slide along. How does that sound, Claire?
Okay. Now you.
Say what slide you're on.
Yes, please say.
Say what slide you're on and say advance slide, and we'll advance them.
Yeah.
Excellent. I'll just say move slide when I want you to move along.
And where are you now?
And I'm on the slide that has a big urban in the middle of a word cloud.
Okay, that's correct. Thank you.
Okay. Effectively, what I'm trying to point out to us is that there are a number of different reasons. I've given you 4 here for why this is the moment to be rethinking the urban health question, the kinds of ideas we use, the practices we invoke, and particularly, I think, given the concentration and the focus of this meeting, the partnerships that we bring to bear in restructuring that urban health agenda. Now, if you move on to the next slide, the reframing opportunity has happened because of changes in the real world, of course. The shift in demography, the concentration of the way and the type of urban forms that we have. But politically and intellectually, the opening up of the space to talk about urban health in new ways comes in large part because of the consensus reached in the 2030 agenda, particularly around SDG 11, the goal on cities, and of course, goal 3. And what this does is that it concentrates the minds, the efforts, the budgets of states in particular, nation states, but in their wake, all the other stakeholders who are engaged in healthcare, health service provision, health analysis, and urban development. And so what we have is an opportunity to reconfigure the global agenda in ways that have the capacity to, and we can think about whether it's important to do so or not, and if so, how, where health becomes the global urban research priority for urbanists, and cities become the lens on health. In other words, that you can't think about meeting SDG 3 without thinking about its application and its relevance and its traction in the urban context. Now, if we do that, and to achieve that, what we have to be able to do is that we have to think differently about the nature of urban health research. And critically, and this is not strange to health people, we have to think about translational research. We have to think about designing systems which we intend to change. For many urban scientists, this is a very new idea. It's one they're not that convinced of. And so it implies a shift in research culture, particularly for conventional scientists and even to some extent for engineers. We also have to think about using very different kinds of methods. And here the challenge is perhaps back to the epidemiological community, where a conventional epi-focus, a statistical analysis, is not perhaps the only form of evidence generation that is going to have impact. We have to speak back into our expert communities and in order to get credible and legible information. Crucially, it seems to me that one of the things that we have to be able to do is we need both local evidence that speaks to particular interventions, but we do also need to be able to aggregate. And I'm going to come back to the question of data and data science, because it does seem to me that this is one of the crucial areas for big partnership discussions around the urban health question. But hold on to that one for now. By implication, we are entering into, and those last bullets speak to that, new frontiers of knowledge that are characterized not just by linear understanding, but which absolutely by definition engage multiple actors, multiple scales, multiple drivers, and we are dealing with complex systems. And so philosophically, we're needing to be able to shift our understanding of who is important, why they are important, what evidence they need, and how they need to be engaged in this translational research agenda in new and different kinds of ways. So if you move on to the next slide, what I've been saying so far is that there is a wonderful opportunity forged through a political consensus around the 2030 agenda, but one that demands a new form of research practice and probably new research partnerships in particular kinds of ways. That's difficult. It's not an easy thing to achieve, and it's probably going to be messier to begin to get into the rhythm of that kind of work. And so sort of work that you've been having presented from, that Andy Haynes is talking about in Kasimu and that Anna was talking about from her project across Latin America, are exactly the sorts of projects that we need at scale that don't at the moment exist. So that's part one. The difficulty is, though, having got all of that kind of information together, who do we interact with in order to begin to shift the global urban health agenda? And by the nature of cities, and actually the nature of health, the constituents that we have to influence are multi-scale and multi-actor. Now, from an urban point of view, this is actually quite difficult. There are, in fact, a number of barriers. So even assuming we knew what to say, it's not entirely clear where we deliver the message. And I'll show you in a second why there are so many multiple follow-up and review processes for 2030. You might think that that's a good idea. Okay, in other words, there are multiple entry points. So have a look at the slides to come when I get there. The really tricky part is that we have a diffuse community that is only really beginning to gain traction and scale up so that it can deliver central messages. And there is no core outside of WHO or UN Habitat, but those are only two entry points within the UN system. And it's a fragmented organizational receptor, if you like, for those messages. And So the combination of the fact that we have a relatively weak science evidence base, we have massive geographical gaps, and we have not adequate understanding of the interactions across the urban system, means that we have actually been, it's quite difficult to have central or core messages. So, for example, the kind of thing I'm suggesting is that unlike the IPCC or the oceans community, who have been able to send out priority messages based on a systematic base of evidence to a global audience, which has the capacity to then disperse across national and local context, we've got a more difficult urban health agenda to put out a less well-organized community and a not very clear audience. So, for example, just to contrast the next three slides. If you just flip through the next three slides, one on the 2030 agenda, what it shows you is the global reporting mechanisms. Now, you don't have to engage the detail. You can make the slides available. But if you contrast that, that's the formal process set up for national and subnational governments, regional governments, to report into the high-level political forum that we were talking about earlier today. I heard Joe mentioning that in the earlier session. That's one mechanism and set of processes where we can land the urban health message. Okay, it's perfectly possible to do so, particularly at the moment when SDG 3 or 11 are specifically under review. But if you contrast that with the next slide on the Paris Agreement, what you'll see there is that actually the mechanisms are quite different. They occur in different times, in different places. Subnational government is constituted differently. There is no regional representation in organization in order to feed into the Paris Agreement. And the third slide, and I know Remy will be able to talk to this in much, much more detail and with far greater authority, shows you what is actually now a voluntary reporting process, potentially a more powerful one, better connected to the local, and probably better connected to some of the core stakeholders. But each of these three mechanisms are potentially platforms for us to say what needs to be said about what needs to change in order to improve health and well-being in cities across the globe. If you move on to the next slide, it tries to bring that together, and I apologize. I hope the Novartis person isn't sitting in the room because that's an appalling squishing of your logo. But if you have a look at what it's trying to do at the bottom, it's basically arguing that we've got multiple powerful opportunities and stakeholders, but there are in fact potentially competing aspirations. What the mayors want, what nation states want, what the private sector wants may not be the same thing, A, and B, we have only limited entry points into these very complicated institutional architectures of the multilateral systems in order to deliver those core messages. And so if you move on to the next slide, which has that graph of the population of the rate of change of the urban population in sub-Saharan Africa. But what I think we have to be very careful about is that we have an extraordinary, unprecedented opportunity to engage and to develop and to generate and to consolidate and to implement a multi-stakeholder, just nuanced global urban health agenda. But it does require some kind of institutional heft, a weight, a leadership that has credibility, which will require us to have potentially some quite difficult internal discussions. And you're going to have some of those in your sessions to come. Actually, is it transportation and mobility that should be at the core? I've highlighted the question there, at least from the sub-Saharan African context, family planning and active health, as possibly one of the keys if you look at the percentage growth rate for the African urban context. Each of these interventions engages a domain of the private sector that is vast. So actually, the supply side for family planning is actually primarily the private sector for much of the world. That's the private sector. It's a different private sector that's engaged in the questions of air pollution. They're related to the issues around traffic safety in the sense that they may be the car manufacturing industry and the tarmac industry and a whole range of the sort of energy debate. But they're not exactly the same, and their interests are not the same. And so harnessing the scientific expertise, the medical expertise, and the operational expertise to know how it is and where it is you can make these changes in cities, including, and I heard somebody saying, in the much more messy, complicated, less well-formulated and understood cities of the global south. That's where we really need to be putting our effort and concentrating our expertise to develop it. And just in trying to draw some of this to a close, I want to remind us that how we do this will matter, and whether we do this will matter, and history will judge us. So what we know is that, of course, citizens shape their cities in probably the most profound ways. But expert knowledge, technology, and the kinds of institutional forms of government that we adopt are also fundamental drivers of urban form, urban life, urban health. And so the box on the left-hand side is a very crude overview of what have been very dominant ways of running cities or of influencing the urban agenda. We know that the public health debate was very powerful in shaping the city in the late 19th century. That gives way to the influence of banking as they begin to develop the stock market and as they begin to get bonds which shape cities and city investment in different ways. Arguably, the engineers then take place. And you can see the voice of the public health officials receding in these new ways of thinking about the city. And implicitly, what I'm saying is that we have a moment to resurrect the question of health and the relationship between the city and health. How that is done and what the focus of that is won't be just on water and sanitation. It's much more likely to include issues of energy, issues of fertility, issues of pollution than it ever has done, will be embedded in law, and they will probably be embedded in the codes and practices of the institutions and the professions who ultimately run the city. There's no question, and I said I'd come back to the question of big data. Maybe it's little data in Anna's words, and a big little. It's the question of data and the capacity to look at patterns and trends in ways that we've not done before. This mass of information about how we live and the ability, in fact, to regulate how we live. The algorithms that were once part of the law but are now perhaps part of the software that shift how our lives are shaped and our health is shaped in an urban context. And it seems to me that this is one very important frontier. If you go to the next slide that starts working brackets on health.
Could you please shorten, because we are already 5 minutes over time, if you could close
I'm in my last
slowly.
slide.
Okay, good.
I'm in my last
Good.
Okay.
Thanks.
All but last slide. And effectively what I want to leave you with is this idea that probably the most important partnership that will be forged in this new relationship around the question of urban health in response to the multilateral opportunity/challenge is around the question of data. And health is going to be one of the really key areas where urban people come together to think about new data. And so I would encourage you to be thinking critically as you engage the new urban agenda about what the nature of health, what the nature of knowledge is, because that is what will determine the practices that we embed in the city going forward. Thanks.
Great. Thank you so much.